I'm going to introduce our next speaker, who will tell you about the Myeloma101. And it's our newest faculty member in multiple myeloma at the Mayo Clinic, Dr. Jeremy Larson, who got his medical degree from Creighton University and then did his residency and fellowship in hematology at the Mayo Clinic in Rochester before he saw the sun and decided that he needed to come to Arizona. And he joined us just in August. Jeremy.
So my task today is to talk a little bit about, essentially the framework for what we'll be drilling into a little bit deeper throughout the rest of the day. And that's what is this disease at its heart, and we'll talk a little bit about the biology. I know when I'm in clinic talking with patients about lab tests, some of this can be, quite technical. So we'll try and break down some of what we're talking about and lay the framework overall for how we make treatment decisions and essentially what the road looks like as we move forward and what kind of symptoms we need to watch out for. So the first slide, obviously this is the critical core question of what is this disease? What is this condition we call multiple myeloma? And, at its heart, as we heard from the video, this is what we refer to as a type of blood cancer or hematologic disorder. This is an interesting condition in the fact it can wear multiple masks, and so classically we think of this as what we call a liquid tumor, but when these plasma cells organize, we can actually see solid tumor formation in what we call plasmacytomas as well. So it can present in multiple different ways. This arises from a cell that all of us have naturally in our bodies. This is called a plasma cell. Its normal neighborhood is within the bone marrow cavity. As we can see outlined here in the center of the diagram, normal plasma cells secrete what we call antibodies, or another name for that would be an immunoglobulin. And so many of you probably know I'm an IgG or I'm an IgA. What that's talking about is the type of immunoglobulin that your specific myeloma cell secretes. And so up in the top right you see a more focused depiction of that. And when we talk about an immunoglobulin, essentially it's two heavy chains linked together to two shorter light chains. And we measure both of those things in the clinic with some of the lab tests we'll talk about in just a bit. So where things become different is when one of these normal plasma cells, for whatever reason, and I will say we're learning so much about the biology, but a lot is still not completely understood about why some plasma cells mutate and ultimately become malignant or cancerous, as Tom Brokaw had mentioned in the video. And so we can see when we're looking at myeloma cells, instead of having a nice family of plasma cells, they're related, but they're not all secreting the same thing. We now have a myeloma cell that has identical copies, that is secreting what we call M proteins, or myeloma proteins, monoclonal proteins. There's many M's you can think about, but essentially what we're saying is that we're seeing an abundance of one type of protein that's being secreted inappropriately, and that has downstream effects in terms of the complications that this illness can cause. Okay, so many of you, before you were ultimately diagnosed or had a loved one that was diagnosed with this condition, it's very possible you had never heard these two words strung together, multiple myeloma. Obviously in this room we're all very, very familiar with this, but when you're comparing across the whole spectrum of cancer, this is actually a fairly small percentage. As you can see in the diagram here, about 1.8% from most recent statistics of all cancers are multiple myeloma. Amongst the hematologic conditions, this is quite common. This is the second most common type of blood cancer behind non-Hodgkin lymphoma. In 2017, approximately 30,000 new cases of myeloma were diagnosed. And as you can see, there's a tremendous number of individuals who are living either with, as we saw on treatment, or in remission off treatment. So in terms of average age, this in general is something that is acquired as we gain wisdom in life. And so median between 65 to 74. And in terms of the spectrum, honestly, it crosses even into younger individuals. It's rare, but unfortunately at times we even meet individuals in their 20s and 30s with this condition. So it can run the gamut. When we talk about what kind of symptoms, what kind of disease burden are we going to need to face and keep a close eye on, I think one of the challenges of myeloma, as I alluded to earlier, is that it can have many different manifestations. And so ultimately at its heart, even though I'm a hematologic specialist, I try to rely on my internal medicine training from many years ago as well, because you really have to be keen to a number and tuned into a number of different subtle signs sometimes. So one of the obvious things, we're monitoring blood counts carefully. Classically, we think about anemia. The myeloma cells within the bone marrow cause abnormalities with red blood cell production. And when we're anemic, as many of you know, we can struggle with things like fatigue, or maybe when you're out for that stroll around the neighborhood, that walk up the hill just feels a heck of a lot more difficult than it used to. So it's what we would call dyspnea on exertion, if you read that in your note. And in terms of low blood counts, occasionally we'll see the myeloma cause a low white blood cell count, or more commonly, the medicines that we use to treat the myeloma unfortunately can affect your normal blood counts as well. So we do need to monitor your white blood cells carefully. Classically, these proteins, or these immunoglobulins we were talking about a few slides back, can cause kidney impairment. Your kidneys are the filtration system of our bodies, and unfortunately these, what we call the light chains, do pass through the normal tubules or the plumbing of the kidneys and can, for lack of better words, gum up the works and cause kidney injury. And because so many things that we give for treatment rely on good kidney function, we monitor this extremely closely as well. And I think these last two on the bottom, referring to the bone damage and bone turnover, are really critical because at its heart, for most patients, myeloma is a bone disease, and we really need to have multiple efforts to maintain that skeletal structure the best that we possibly can. So as Jack had alluded to earlier, unfortunately one of the ways that this can show up is with simple things, shutting the car door, putting on a t-shirt, and we feel a pop. And that can be a sign of what we call a pathologic fracture, or in an area where there's bone weakening, as the myeloma has dissolved or degraded part of the normal bone structure, we get an area of weakness. And we can see pain issues, ideally with early recognition and minimizing damage to the skeleton. Hopefully chronic pain is limited as much as possible, but unfortunately even after myeloma is in remission, many patients do struggle with bone pain from prior injuries. And I think one interesting thing at the bottom, and some patients accuse me of making them sick when they weren't before, when we start treatment, and I try to back off of that ledge a little bit, but sometimes this is found incidentally. You show up to your primary care doctor, all is well, it's the once-a-year checkup, and someone is maybe astute to, there's a new anemia here, but you don't feel it. Or perhaps we see when they're measuring one of those total protein lab numbers, the globulin levels are inappropriately high, and someone decides to do some digging, and ultimately a diagnosis of myeloma is made. So it's not that you have to be, sick or life is falling apart when this diagnosis is made. Many patients are very, very functional, and our goal is to maintain that and prevent myeloma from doing what it is known to do. So we'll walk through a little bit of this step by step, but I think this is a nice outline for, as I'm meeting a new patient with this diagnosis, of how we begin to approach and formulate a treatment plan. So these first two, I would say, really are the information gathering phase. We're trying to figure out, what is this myeloma we're up against? What's the burden of disease? What areas in the body has it begun to affect? And so we're going to use help of radiology tests, and we'll talk a little bit about this. We'll use biopsies to gain information about what's happening in the bone marrow, and ultimately figure out what type of myeloma this is. At myeloma conferences, we like to sometimes joke that there truly are multiple myelomas, and the fact that all of you in this room likely can be divided into many different subtypes of myeloma, and we're trying to dig a little deeper into the genetic basis of this so we can tailor therapies. I was talking to some of you earlier, this point number 3, as a clinician at Mayo Clinic, oftentimes I am seeing patients, perhaps after they've already learned of the diagnosis, and we're sitting down for a consultation. And some patients, honestly, they're a little bit skittish to tell their doctors that they've decided to come to Mayo Clinic, as they're afraid they're going to step on someone else's toes. They really like their doctor at home. And I try to reassure patients that a second opinion is something that almost exclusively people welcome. We want to get as much expertise on board, and so never feel shy about going to a center of excellence. And as Dr. Bergsiegel mentioned, here in Arizona, we're fortunately blessed with a number of truly top-notch myeloma centers. And I think making yourself an advocate for this disease. Ultimately, at the end of the day, you are the one living it 24/7. And so as much information you can gather, and there are tremendous resources out there. Fortunately, MMRF, I think, is one of those true blessings that we have, who've been a tremendous advocate for patients. But as you start to learn what are the options for treatment, you can start to have, I think, a more balanced discussion with your physician about your treatment preferences as well. And this last one, number 5, trials are so important to the way we move our treatment forward. As you look at the survival curves that Dr. Bergsiegel was just showing you, this would not have been possible were it not for those patients that enrolled on clinical trials and made us smarter about our treatment decisions. I think in an era, unfortunately, I think this precedes my arrival to the scene a little bit, but there was an era in clinical trials where I think it sort of got itself a bad rap in that maybe there wasn't the best scientific rationale for these drugs. We were sort of throwing things at the wall to see what sticks, if you will. And I will say that is not the case at all. The science has moved forward so much that these are very rationally designed, well thought out trials. And so this is one of the best ways to get access to cutting edge novel therapies that aren't things that we can prescribe off the shelf quite yet. So, multiple myeloma is an interesting condition in the fact that this protein that we talk about and measure, the M protein or the myeloma protein, is one of the ways that this diagnosis ultimately is found. But the interesting thing is that there are precursor conditions. So as you can see on this graph, there is a spectrum. We've been talking about that right side of the page here, multiple myeloma, which are when we see complications arise. It's caused bone injury, we're anemic, or we feel sick, for example. These other two conditions to the left, which one of them goes by the funny name of MGUS, which you can thank Dr. Kyle, as we referred to earlier, for this name. The shortened hand is MGUS, or MUGUS if you prefer, or monoclonal gammopathy of undetermined significance. Say that 10 times quickly. And what that is referring to is when this protein is found, in many cases, that this is not actually a diagnosis of myeloma, that it's something that can be watched and observed, but it has a malignant potential. And so you see at the bottom approximately 1% risk per year of ultimately transforming to a condition such as myeloma or one of its relatives that would require treatment, but many patients live their entire lives without ever needing any treatment for this, just observation. And one of the keys is that they have a small amount of this protein, so it's defined as less than 3 grams. When we do a bone marrow biopsy, there are less than 10% cells, so that's an important line in the sand when we're helping to decide what category we fall in, and know what we call myeloma-defining events. And you'll probably hear what we call CRAB criteria, and that CRAB there is listed at the bottom, and it's a helpful reminder to kind of jog your memory of, okay, what kind of things is your doctor looking for when they're making this diagnosis? So is the calcium irregular? Is it high, classically? Is there kidney dysfunction, so renal insufficiency? Are we anemic, or are there any bone lesions? And so you can imagine when we're looking for these things, it's a little bit of a hunt in terms of lab tests and radiology tests to sort some of this out. This category in the middle, which I know some of you in this room have been given this diagnosis of the smoldering myeloma, and this is what I would categorize as an intermediate stage. We're no longer in that low-risk MGUS of 1% per year. We're now closer to 10% per year, and really where this is coming from is the fact that there's more of this protein, and there's also more of these plasma cells that are present in the bone marrow. And in the last several years, the way we diagnose myeloma has been adjusted. You can see in the bottom column on the multiple myeloma section that in addition to those CRAB features, we have now added a few other criteria that previously you would have been in the smoldering category that we have now upgraded to multiple myeloma. And part of the reason is these individuals, even if they haven't yet shown abnormalities on x-rays or their bone marrow, we know they're a very high risk for progression to myeloma, and so we no longer wait for that other shoe to drop. So as a patient, part of the education of these tests, I know one of the nice aspects of modern medicine and technology is you can actually access these yourself. You no longer have to have kind of a filter of just what your doctor tells you. You can actually see your own labs yourself, and you can begin to educate yourself of what your trend is. I have a number of patients who come in with the Excel chart, and they've got everything plotted out, and I think it's honestly wonderful. As I said earlier, you really do need to be an advocate for yourself. So some of those basic tests that we're looking at would be what we call a CBC, or a complete blood count, and that's what's going to tell you your white count and your red blood cell count. The CMP is one of these jargon terms. For a more simple way to think about it is your metabolic profile. So what are the salts in the blood? What is the kidney function? What is the liver function? The beta-2 microglobulin, which is in the middle, the B2M, we use this at the very outset for staging. So really this is most important at the very earliest phase of the myeloma, and that's part of the way we determine that staging. And the SPEP is it's shown as you see this little diagram of the two big hills there. So what that's basically doing is sorting out these types of proteins in the blood, and we can find that myeloma protein, as you can see towards the right, where we see that second big hill, that's the myeloma protein we're measuring. So this will report out the amount of the M protein, or the myeloma protein. So this is one of the test questions at the end, so I'll give you a little cheat, because I expect 100% here. We're not letting you leave until you get all the questions right. No. So the SPEP is one of these really important tests that we use to follow the disease, and most patients will secrete this protein. And I sometimes make the analogy, this is sort of the the cookie crumb trail the myeloma leaves. So we can do a liquid biopsy ongoing with blood work. We don't always have to do radiology tests or bone marrow biopsies if otherwise we have an easily traceable marker in the blood. And at the bottom, these last two just help give us a little bit more information about the myeloma protein again. So the immunofixation, or what's abbreviated as IFE, tells us what type of immunoglobulin you have. So if you're an IgG or an IgA. And it also tells us what the light chain is, and so whether you're a kappa or a lambda. And lastly, the free light chains are also an important way we follow this. Some patients, as I think I'll show you in the next graph, have what we call light chain only disease. So that initial test to follow the M protein may come back negative, but in about 1 in 5 or 1 in 6 cases, patients only make light chain. So maybe you are familiar with I'm only a kappa, or I only make lambda, and that's the test that we would use to follow. And unfortunately, in approximately 3% of the cases, we don't have an easy marker to follow either in the blood or the urine. This is what we call non-secretory. And in these cases, we do really rely more heavily on imaging. We watch symptoms carefully. And of course, bone marrow biopsy is always the gold standard to go straight to the factory of where these plasma cells are hiding. Okay? And lastly, in terms of labs, this would be the UPEP. So this is a cousin of the SPEP. Instead of the serum, S, we're using urine, U. And many of you are probably familiar with the joy of collecting the bucket for 24 hours. This is the test that you're doing this for. And again, it's finding these abnormal myeloma proteins, what we call light chains, out in the urine. And fortunately, with the advent of that test we call the free light chain assay, essentially that serum test is measuring very similar information to the UPEP. So in many cases, unless we're at a pivotal point where we need to change treatment, perhaps looking at new options, we can measure the serum test and hopefully not make you collect the urine every month, for example. So radiology-wise, we have a number of options to look at. Historically, we've used skeletal surveys. You can see the X-ray on the left showing a compression fracture or an area of weakening in the spine. But the MRI and CT shows us much higher resolution information, and we've now started to integrate PET scans as well, which give you some functional information. So as you can see, there are a couple of areas on that PET scan that are glowing in the spine, and that's an area of active myeloma. So the bone marrow test is one of those necessary evils, I will say. Hopefully these have not been too traumatic of an experience for you in the past, but it's a really critical piece of information for us. This is sampled from the back of the hip bone, what we call the iliac crest, and that's going to pull out some of this liquid material that we can then use to help determine some of the genetics of this, which we'll hear so much more about later this afternoon. So this is going to do sequencing. We can look at what we call FISH testing, which right now is one of the easiest ways that we learn about rearrangements of this genetic material that also helps in the staging. I won't spend a ton of time on the precision medicine since you're going to hear from the experts here very, very shortly. But I think the main takeaway is we're starting to drill deeper and deeper into the sequencing. FISH, that test that talks about rearrangements, looks at large rearrangements that we can spot. But we know there are many subtle mutations that we're now learning about, and we're just at the very beginning of this revolution of individualized therapy in myeloma. And we heard a little bit before, we're going to hear so much more about the COMPASS study, which some of you may have already been participants in, and this really will be such a huge step forward as we learn more and more about who does respond best to therapy. Myeloma is a complex disease, and the fact that there's not just one mutation that we can use one drug, and so really trying to personalize therapy the best we can, I think, will be a major step forward in treatment. And in terms of knowing your myeloma genomics, there are a number of different tests that are available. So tissue banking is something that if you're at a larger center of excellence, that likely this is something that has been done. You can extract DNA for future use. Tests that are available, we talked a bit about that FISH test, which is a standard test done at diagnosis, but now more and more we are going on to do what's known as next generation sequencing, which drills down into the single kind of base level to learn about what mutations the myeloma has acquired. And a common thing that comes up when we start talking about genetics that I think is a really important distinction is that we're talking about abnormalities in the myeloma. This in general is not what we consider a hereditary disease, so we're not talking about mutations that will be passed to son and daughter. These are abnormalities that the myeloma has acquired. And at the end of it, we have all of these various pieces of the puzzle that we're going to put together, and we're going to sit down and we're going to synthesize this into a treatment plan, because ultimately that's the goal of all of this, right, to help make us better. And so this first staging system that we talk about is what we call the Revised International Staging System, or the RISS. And this was revised in 2015 to integrate some of the new material we have about genetic information and how that plays into prognosis. So we look at some of those FISH changes. There's 3 that we identify as high risk by this, which I won't drill you on today, but 17p, 414, 1416, these are some of the numbers that you'll hear again today. And we look at some of that blood work, and we help to decide, are we a stage 1, or are we in the middle and a stage 2, or a stage 3? And from a standpoint of staging in multiple myeloma, this is different than some tumors like breast cancer, lung cancer. This doesn't necessarily change the way we treat disease. It does really play into prognosis, however. I think this is a little bit maybe of a simplification, but when we're talking about where do I fall on that spectrum, do I have kind of a bad myeloma, if you will? We are trying to answer that question. We do this FISH testing, and so the majority of patients will fall towards the right of this graph, either in the standard risk category, what we call hyperdiploidy for many patients, where they have extra genetic material or extra copies, or intermediate risk, which is defined by 414, or a high proliferative rate when we look at how many of these cells are dividing under the microscope. In about 15 to perhaps 20% of cases, we'll fall into this high-risk category to the left, and that's really an area of unmet need where patients can still respond, but if you look at the averages, the amount of time spent in remission is shorter, and that's an active area of investigation. So in terms of big questions, and this is something that's available as well in the slides, but these are really critical questions, I think, to answer when you are having that consultation with your physician. So learning about what type of myeloma do I have? What's the stage? What are the genetics of my disease? And really having an honest and candid discussion about long-term prognosis. We'll talk more about the precision medicine movement here a little bit later this morning, but this really is the cutting edge of Myeloma 2018, and what treatment options do I need to consider. So we'll talk a lot more about treatment here later today. I won't dig into this deeply right now, but as we think about broad categories of treatment, if we're in the active myeloma category here to the right, we think about am I a stem cell transplant candidate, or am I not? Am I going to use medications to control my disease? What have been my prior treatments if I'm in that relapsed category? Can I recycle old drugs that worked well previously, or do we need to think about new combinations? And then also protecting the skeleton with bisphosphonates, or you may be familiar with some of these medicines known as Zometa, Oredia, or we now have a newly approved medicine known as Xgeva. These are all meant to help increase the structure of the bones. And then in the middle category, the smoldering myeloma, classically our standard is observation, monitoring carefully. However, if you do have a clinical trial available to you, there are so many novel agents now that are even being tested in the smoldering myeloma. This is an area of extreme interest as well. And so this is just to highlight, if I kind of shift your focus towards the right side of this graph, you can see all of the activity. So Dr. Bergsegel was mentioning for many decades, myeloma was unfortunately a little bit of a backwater, not for lack of effort, but the drugs just weren't available. And really beginning in 2003, we had a huge step forward with Velcade or bortezomib coming to the clinic, and we now have next generation compounds, immunotherapy coming to us. So 2015, if I point your direction there, you can see there are a whole lot of activity happening there. And this is continuing to build momentum. So this is what we expect here in the near future. You can see towards the right of that curve, lots of immunotherapy options and targeted molecules that are based on what we now understand of the biology of the disease. So I think this is obviously an incredible step forward from where the history of myeloma has been. And just to summarize, so myeloma, of course, can have multiple effects on the body. We talked about the anemia, the CRAB criteria, protecting the bones, protecting the kidneys, the genetic information that is now becoming so important to help tailor our therapy as we make these decisions about which drugs we may use. Survival is gaining by leaps and bounds, and we're not done. This is continuing to improve. And lastly, the treatment paradigms will continue to evolve as new medications become available. So just to wrap up with a couple of questions, and we'll start with the top here. Which of the following is or are true about multiple myeloma? A, myeloma arises from a more benign process known as MGUS or MUGUS. B, autologous stem cell transplant is more commonly used in the management of myeloma. C, genetic information from the plasma cells helps to stratify a patient's risk status. D, patients may be patients may be diagnosed with multiple myeloma even without having a single symptom. Or E, all of the above. Okay, let's see how we fared. Oh, there we go. Oh, right. Sorry, I'm completely ignoring the right side that is 90. Okay, you guys all got it right. You don't need to be here. Go home, enjoy the sun. No, fantastic. So that's wonderful to see. You guys are cream of the crop. Oops, let me skip back. So we'll move to the next question here. So my multiple myeloma disease activity is primarily measured by A, blood test M protein, so your IgG, IgA, etc. B, blood test free serum light chains. C, 24-hour urine testing. D, bone marrow biopsy. Or E, I don't know. This is tricky. We order multiple of these, but which you think is the most commonly to be used? Excellent. So the correct answer would be A, or number 1, but honestly, this is a little bit of a misleading one as we honestly measure the free light chains. We do track bone marrow, so all of these are important tests, but excellent. All right. And with that, I think we will hand it over for, see if we have any questions to resolve.
We don't have a lot of time. Sure. And what I'm going to do is I'm going to look through the questions and I'll ask the ones, just a couple now, that's all we have time for. But as the day goes on, I'll put them together and I'll ask the other questions, so don't feel you're being ignored. But one, just related to your last slide there, how can a person have a low level of M protein but still have bone lesions?
That's a great question, and I would say ultimately it comes down to the fact that we're using it as a surrogate marker or a secondary marker, and for most patients the amount of M protein tracks fairly well with disease activity, but unfortunately I can meet patients with a very small amount of M protein, but unfortunately their plasma cells behave badly despite the fact that they're not secreting a lot of protein. So it's an imperfect marker, to be quite honest with you. We use it because it's a good tool, but it's not the full story. So that's why we do need to watch symptoms. We have those routine clinical checks where it's putting all of the pieces together, to be honest, and that M protein is just one piece of the equation that goes into it.
And I hear the term remission being used today, but I'm told that remission should not be used with myeloma. What does this actually mean, and what is relapse?
Okay, that's a talk in itself, and I think that's one of the most common areas of confusion that comes up when I'm talking with patients. When you hear myeloma doctors use the word complete remission or complete response, what they're essentially alluding to is on the bone marrow biopsy, we have no detectable myeloma cells, and out in the blood work, we no longer see that abnormal protein, or the M protein is not detectable. The difficult thing, and a lot of us use the iceberg analogy, is when we're measuring these things in the clinic, you're picking up high-level myeloma, but unfortunately, we know the challenge with this disease is that at a very basic, even cancer stem cell level, there are cells that ultimately will, in most cases, lead to a recurrence down the road. And so that's why many of us are a little bit shy of using the C word in the form of cure with myeloma, in that most patients will require future treatment down the road, even if they are technically in remission. So it's a little bit of semantics. But hopefully that helps to clarify a little bit. When we're using the term remission, what that means to me is that I can't detect the disease on our standard clinically available tests. Thank you so much.